a real fascinating finding that we've had in prostate cancer recently. Prostate cancers, they're a variable disease. They can go very, very slowly or they can go very fast. So when they happen in young people, young men, they're usually very aggressive and they have some negative features. We know what those negative features are. Often these patients become castration resistant very quickly. So we've had a few cases where we've thrown everything at them over the years and nothing worked. So recently we had a young man, 57-year-old man with prostate cancer. It was a fairly aggressive one. He caught it early. He came to us. He said, I want everything done on this. I want all the best. And so we said, okay, well, you need to have a proper resection. You need to have your tumor taken out for one. So we took his tumor out, we sequenced it. We found that he did have some aggressive mutations. He had a P10 deletion, which is a sign of early castration resistance. And he also had some lymph nodes in his pelvic region. Now, normally what happens is they will just treat these with radiation, or they'll give you something called androgen deprivation therapy. And in Canada, prostate cancer treatment is kind of sequential. So they'll start with androgen deprivation therapy, and then often they'll add if that stops working, they'll add an androgen receptor antagonist. And then when that stops working, they'll do chemo. And then for the ones that can afford it, they will do something called lutetium. And lutetium is a class of drugs, or it's basically a radioactive isotope, but it's attached to a small molecule, or it's an antibody, but it's actually a small molecule of an antibody that targets something called PSMA, prostate-specific membrane antigen. This is an antigen on the outside of most prostate cells, regardless if they're cancerous or not. So PSMA, in this case, is used as a target to have a selection of these cells. And so this lutetium treatment, basically what they do is they inject it into you, and the PSMA antibody attaches to the PSMA molecule on the outside of the prostate cells, and it attaches a radiation to it and kills it directly that way. So it's called theranostics. And this has led to the development of a new technology called antibody drug conjugates, where you're replacing the payload that is normally radiation in theranostics to a drug, chemotherapy agent, or even a targeted agent. So this has been a real advancement in how we treat cancers. It's like targeted chemo. So in prostate cancer, if you have high PSMA on your tumors, then you can treat them with this lutetium, and it works quite well for a few years. However, many prostate cancers lose this PSMA expression, or just have low PSMA expression on them, and therefore this lutetium doesn't work for them. So what we found is, and this has been known for a while, that some aggressive prostate cancers avoid or become castration resistant by turning into what we call a neuroendocrine cell. So this is a different type of cell. So it's a prostate cell turning into a tumor, and then the tumor turns into a neuroendocrine subtype. And so in this particular case, this individual had this aggressive cancer. We caught it we're with him right off the bat. As soon as he was diagnosed, we caught it early. We got him surgery, and then there's 3 lymph nodes left. And so he said, well, should I just get these taken out instead, or irradiated? And so we said, well, obviously, if you can have them taken out, that would be the best case scenario. So we had a doctor in Mexico take out these 3 lymph nodes, and the doctor tested them and found that one of them had transformed into a neuroendocrine subtype. So we were like, wow, you dodged the bullet on that one. Had we just hit it with radiation, it probably wouldn't have killed it. It would have really ripped through his body, and he probably would have been dead in 1.5 years. So, it was very lucky that this patient was able to afford to go to Mexico and have these lymph nodes taken out, and to find that he had this neuroendocrine differentiation. So when he came back to Canada, his doctors acted on that information and said, guess what? We're going to give you the neuroendocrine chemotherapy protocol. So they gave him this neuroendocrine chemotherapy protocol, in hopes that it would prevent any further, metastasis and clear up, any loose floating neuroendocrine cells. But we went one step further. We took that neuroendocrine tumor and we did our full analysis on it. We did an RNA expression testing, tumor RNA expression testing. We looked at all of the 21,000 genes, just under. When it came back, we were shocked. This did not have, it basically had the pathology of a neuroendocrine tumor, and that was it. In other words, if you look at it through a microscope, it's going to look like a neuroendocrine type of tumor based on certain markers that they use in pathology, but the genetics were nothing like a neuroendocrine tumor. So normally neuroendocrine tumors have what's called somatostatin receptor expression, and we find that there's two types of neuroendocrine tumors. There's low grade and high grade, and then there's a range in between. So if it's low grade, it typically has somatostatin 2 receptor expression, and that's used as a target to treat it. If it's high grade, it usually doesn't have somatostatin 2 receptor status. It has somatostatin 1 or somatostatin receptor 3 or 4. And we don't have drugs to target those other receptors. We only have drugs to target 2. So high-grade neuroendocrines are usually characterized by a lack of the number 2 receptor and overexpression of the other receptors. We didn't see any somatostatin receptor expression. We didn't see any other genetics or genes expressed with neuroendocrine. What we did see is a lot of genes and overexpressed markers and cell surface receptors that are commonly found in ovarian and breast cancers and cervical cancers. So this tumor cell, this neuroendocrine tumor cell, or this prostate cancer that it was showing itself as a neuroendocrine cell, was not a neuroendocrine cell. It was more like a breast cancer or ovarian cancer. Fascinating, but that explains why the neuroendocrine protocol doesn't really work on patients with prostate cancer who have transformation. It just doesn't seem to work at all. And it's because they're not really neuroendocrine cells. They're tricking the pathologist into thinking they're neuroendocrine cells, but they're really more like a breast or ovarian cancer. So because of that, we were able to identify high expression of certain markers that are associated with different new advanced breast cancer treatments. So we know how to treat this patient now, and it's very counterintuitive. So this is a groundbreaking finding. This is really changing how we treat cancers and to not take things at face value.